So welcome to Mastering CVD Risk Assessments, Essentials for General Practice. I'm really excited that everyone's here and come to refresh our knowledge and make sure we've got all the ins and outs of the new risk calculator and how we can be referring our patients on to reduce their risk. So we'll get started. Any questions, more than welcome to put them in the Q&A or the chat at any time, and we'll take breaks throughout. Okay. So I'd like to start first by acknowledging the traditional custodians of the land on which our work at the PHN takes place. So for me this evening, I'm on Wurundjeri land, but we also cover the lands of the Bunurong people and the Wathaurong people. So I'd like to pay my respects to their elders past and present, as well as extend my welcome to any Aboriginal or Torres Strait Islanders joining us today. I'd also like to acknowledge that this land was never ceded and it always was, is and will be Aboriginal land. So we'll just kick off with a little bit of housekeeping to start with. So we have popped you on mute so that we can't hear all your lovely fur pets in the background making barking, meowing noises like mine is. Questions in the chat box, if you please, and I'll keep an eye on that one and I'll cover them off as we go along. This session is being recorded, so for those that couldn't join us this evening, they can watch back later. And I'll just request that you do actually change your Zoom name to the name that you registered with, particularly for those that would like a certificate for RACGP CPD hours. We need to know that it's you. So if you need to know how to do that, the instructions are up on your screen, or if it's just all too much, just pop your name in the chat and we will pick it up from there. Okay, so we are so very lucky to have three really experienced and passionate people to come and talk to us this evening. Our first speaker, after you listen to my dulcet tones for a little bit, will be Dr. Ralph Ordem, who has informed me that he's now got over 35 years experience in general practice and lecturing and spreading the good word, all things diabetes and heart disease and many other things. And he's always a really engaging presenter, so I'm really excited to have Ralph along tonight. We also have Lauren, who's a senior practice nurse at Westview Medical Centre out in Werribee. She has a postgrad degree in community and primary healthcare nursing, and she has a love for all things chronic disease management and preventative care. So I'm really excited that she's come to share the nursing perspective on heart health checks. And last but by no means least, we have Eleni Kaias from Diabetes Victoria, who is their primary healthcare liaison. So working with us all primary care practitioners to make sure that we're engaging patients the best way that we can to reduce their risk of not only heart disease, but also diabetes. But we will have a heart disease lens on that this evening. So to start, I thought it might be useful to review the status quo in our catchment, the northwestern Melbourne, where we're sitting in terms of both risks and heart disease at the moment. So northwestern Melbourne, we are large and mighty. So we cover at our 2018 health needs assessment, which we're just about to do another one. So we had 1.9 million residents, about 632,000 of which were born overseas. We have over 200 different language groups in our catchment, 5 Indigenous nations, and we also have the largest humanitarian arrival population in Victoria, although we might find we might lose to Mildura on our health needs assessment on that one, but really diverse community, all with their own unique challenges and benefits. So looking at risk factors, and cardiovascular disease risk factors, obviously. So fruit and vegetable intake, unsurprisingly, including me, we're not meeting the daily recommended intake of 2 fruits and 5 servings of vegetables per day. We do have an unhealthy reliance on takeaway meals, and the salty snacks certainly well up there. So we can already start to see those lifestyle factors creeping in just as a routine part of people's day-to-day choices. Nearly half of adults not meeting the physical activity guidelines of 150 minutes per week. We have a decreasing, thankfully, but still a reasonable amount of smokers, particularly daily smokers in our catchment. And over half of adults drink at levels that increase the lifetime risk of harm. So 2 standard drinks or more on any day of the week. So we're already starting, and again, not just heart disease, other risk factors as well, but consistently there's quite a few things there that over long term are going to contribute to that cardiovascular disease risk in our population. When we're coming down to the metrics, high blood pressure, about a quarter of adults have a history of high blood pressure, although we were quite good. 80% of patients who have seen a GP have had their blood pressure recorded in the previous 2 years, which is a lot better than a lot of other areas. So we can all pat ourselves on the back for that one. In terms of high cholesterol, about a quarter of people over 65 had high cholesterol. But it's that 10% of people between 45 to 64. And we know aging population, that percentage is going to rise. Or, well, BMI, it's not a perfect metric, but it's a metric that we have. About half of the adults in our catchment have a BMI of 25 or higher. So where does this all pan out in terms of our risk of heart disease? So this is from the Heart Foundation's Heart Maps, which I've popped the web address at the bottom, so you can go and do a bit of a deep dive into the data yourself. So looking at the data on the left, so that's referring to the west of Melbourne. So above the national and Victorian rate of heart-related hospital admissions, and unfortunately also above the national and Victorian rate for coronary heart disease mortality. In the northwest region, heart-related hospital admissions well above the national and Victorian average, but we're actually below in terms of mortality rates. So number of tertiary facilities and that population difference between what we see now in a north and west catchment and the outer west catchment in terms of risk factors and healthcare access. So this is my little pet project that I like to talk about. So I think my background before I was a program officer at the PHN is practice nursing. And as a practice nurse, I've done many a health assessment in my time, and I know how valuable they can be at actually allowing you the time to go through and do a comprehensive health assessment with your patients and do the lifestyle counselling that I think we actually all really enjoy doing, and that does work for patients. So when I looked up our data, so this is based on Australian Institute of Health and Welfare data, looking at MBS claims in the 2022 to 2023 timeframe, looking at our health assessment cohort. So really we're looking at that 40 to 49 diabetes risk assessment. We're looking at the 45 to 49 health assessment. We're looking at our 699 heart health check. When we look at the age cohort of 45 to 64, so in our catchment, we have a population of about 399,000 people in that age cohort. So of those people, 95% of them have seen a GP in that time frame. Only about 3.5% have had a health assessment item claim. So that's the 700 suite or the 699,177. So that equates to about just over 14,000 patients out of that potential 398,000. When we're looking at the 65 to 79, obviously we don't have the range of health assessment items available to us that we do in that younger cohort, but we still have our heart health checks available for those that don't have pre-existing cardiovascular disease. Again, about 164,000 people in that age cohort, equates to about just over 14,500 patients. 8.8% of that population has held a health assessment, but 100% of that population have seen their GP at least once in that time. I think in the current environment, we are all feeling the squeeze in practices financially. I think changes with my Medicare, the terror of payroll tax is all sitting in the back. And I think it is a really hard time. A lot of practices are going from bulk billing to a mixed billing system just to keep the doors open and being able to service our patients. So I always do like to highlight that health assessments, fantastic for patients. Patients value having that one-on-one time to actually comprehensively discuss their health They love it. It's such a good way to continue to build that rapport with your patients. It actually gets us back to caring for patients, which is the reason I think that we all got into healthcare to begin with. The other thing is they are the bigger billing items, and your practice nurse or Aboriginal health worker's time is taken into account when you're looking at the health assessment items. So I have included just a little table down the bottom. So looking at if you are doing this work, you can be fairly remunerated for the time that it takes, and you can utilise the resources that you have in practice in terms of staff. So I'm sure you've had enough of my voice. So let's go on to someone who's much more interesting and vibrant than I am. Dr. Ralph Ordem, the wonderful from Carlton. Take it away. Talk heart disease.
Thank you for that introduction. And look, let me say, I was a bit surprised. I thought the burden of disease out in the West would have been actually much greater than what's coming up on the figures. So it'll be interesting to track that over time. The other thing is that if you are doing the health assessments, yes, they are higher paying items. But what a lot of people don't realise is if you find something, you can then do a care plan, and then a plan, and then you can do a review, and so that actually does work well into your how shall we say, the financial viability of the practice. And I have no qualms because we know reviewing care plans has great outcomes. Anyway. So I'm going to talk about the risk calculator. Of course, everyone knows now that there's actually a new risk calculator. And of course, there's been a whole lot of issues around that because the risk calculators that we have, or we had in our eHealth records, were no longer correct. And so people like Best Practice have now turned them off, which means that we now have to go to a website if we want to do it. But that hopefully will be fixed sometime early next year. They're working on it as we speak. But I mean, why do risk calculators in the first place? Now, the whole idea is you've heard all the individual risk factors, and any one of them you can say, well, yeah, we can manage that. But it's when people have a cascade of multiple risk factors coming together that the actual risk really goes high. And sometimes people can just be a little bit above in each of the elements, but when you put them together, it puts them at a very high risk, and something that we need to do about, which is, the whole idea of making sure that we actually assess people, not just trying to judge it, but actually do a formal assessment of where their risk is. Because if you know what their risk is, you can then relay it to them, and then you can do something about it. So why I'm here is from this data here. So this was from a Queensland hospital looking at all acute coronary presentations. And they pulled out specifically those people who were there with an acute coronary syndrome, but hadn't had a previous cardiovascular event. So newcomers, they were at high risk. Only 1 in 5 of those people who had a high risk score were actually on treatment, right? 1 in 5. So if we would have done a health assessment, a heart health check or risk assessment on them, we could have prevented a lot of those infarcts from happening. And that's not the answer. So this one was looking at from Charlotte Hespy in Sydney. She's got a big database. And again, when they looked at those people on the database who had a very high risk of a cardiovascular event over the next 5 years, about 40% were actually on treatment. So a little bit better, but you can see the number of people that actually got to target was in fact very low. So again, once you know someone's at high risk, we need to treat them, but then it's also on us to make sure that we get them down to a target to make sure we stop them having that first event. And this one's getting a little bit older. That was a population based. And again, less than 1 in 5 who are at high risk were on treatment, and less than half of those that were on treatment actually got to target. Just going to that Queensland data. So what really surprised, and I know this is about primary prevention, but I've always got to put a plug in here. 1 in 3 people who attended for, that hospital with an acute coronary syndrome had had an event before, right? So that's secondary prevention. I can tell you half of them weren't at target. So as a group, we know they're at high risk, we can do something about. The next quarter, these were the people at high risk. Now, high risk is a smaller group, but they represented nearly a quarter of the population of people turning up with acute coronary syndrome. And again, as you heard before, most of them weren't on treatment. So in these two groups, which is more than half of all the presentations for acute coronary syndrome, we could have done something to stop them getting there in the first place. All right, so this is important. So why the new calculator? So this is the old calculator. I used it for years. I talked about it, but it was based on a town in America. It's what, 60 years old, that where it first started, and it's based on a very much a white Anglo-Saxon population. And so really what they found was that it overestimated the risk for most of us, which is interesting when you consider the population. But from their metrics, they felt that it overestimated. So in here, I've put someone who's 60, slightly high blood pressure, slightly elevated cholesterol, HDL down a little bit. And under the old calculator, that would put them at very high risk. Okay, so normally we would say, treat them with statin, treat them with blood pressure tablets, do all your lifestyle, and away we go. I've used exactly the same parameters. So this is what the new calculator looks like. It's cvd.check.org.au. And you can see it's a little bit different. So in the first one, we had a whole list of people who we thought were automatically at high risk and that we didn't have to do a calculation on. Well, they've actually fine-tuned it. So, you can see who it's for, but the only two things that actually stop you from then calculating a risk are those people with moderate to severe kidney disease and those with familial hypercholesterolemia. So think of all those other people we put automatically in a high risk category. We can now actually do a risk calculator on them. Now, I've done exactly the same thing. 60-year-old male, never smoked, blood pressure is 143. I entered in the cholesterol just the same as we had before. You can see here, it's actually asking now for whether people are already on blood pressure or lipid lowering agents. So it's already a little bit, a bit more finessed, asking about fibrillation. And this is really new. We know that where you live, your postcode and your socioeconomic index does have an impact. And so they now put your postcode of where they live to actually put that into the mix as well. Then you can hit calculate. Now, same parameters. Now, I've got to say also, the percentages have changed. So in the past, we said less than 10 was low, 10 to 15 was intermediate, 15 was high. That's all been shifted to less than 5 is now considered low risk, 5 to 10 intermediate, greater than 10 is now considered high risk. And I know this is a real pain because you've got all those wonderful calculations in the past that we can't use anymore. But using the same parameters that we did on the old one, you can see that that person now falls within the intermediate risk, which gives us time to say, well, we can put in lifestyle. If there's a particular, maybe a risk factor that's higher than all the others that we think really needs to be treated in its own right, we may do that. But you can see it's now calibrated down to a lower level. So, and that granularity is important because, like I say, it was over categorized in our previous calculator. Why is this one better? It actually comes from New Zealand data. And New Zealand's actually very close in many ways to our population. And so they've used the population data from New Zealand and their risk equations, and then they've made a little bit of an adjustment for the Australian population. So then you can see what they've got here is, some other, what I always call the fudge factors. you know. So there you are, you've got someone, they're intermediate risk, you're wondering, well, is that a real true reflection? So you can see they've got a calcium score. So in that intermediate group, if you really think, nah, this person's got to be high risk, I'm sure of it, you could do a calcium score, you know, the coronary CT calcium score. And if it's high, it's high. If it's low, it's low. So you're using it to reclassify them. People from an Aboriginal background. Interestingly enough, of course, the New Zealand calculator was done against Maori and Pacific Islanders, which is a very different population. So this will certainly underestimate the risk of our Indigenous population. Then they've got the Maoris you can still put up. Family history. So now, interestingly, it's not, doesn't actually form part of the equation, but if you're really worried, you can put it up. You know, if there's a big history of premature history within the family. CKD again, so not that sort of moderate to severe, but that more moderate to mild. And notice down here, we've always been concerned. We know that people with low prevalence mental health issues have basically a 20-year loss of life compared to the rest of us. Most of that's actually driven by heart disease. And so if you have someone with a low prevalence mental health issue, you would automatically classify them up a whole category. And you can go down. Right? I've gone for the ones that go up because I think they're really important. But, you know, if you've got someone who's got a coronary calcium score of 0, their risk for the next 5 years is incredibly low. So if they were like 12% high risk, but they had a 0 score, you would use the calcium CT score. And of course, some of our, you know, Asian cohorts have a lower risk compared to the rest of us. So that's the new calculator. But wait, there's more. It now has these nice little diagrams rather than just the heat chart saying, you know, green, red, orange and red. They now have a chart so that you can use this to explain. So for this person at intermediate risk, it means for that person, if there was 100 people just like that person, 8 people over 5 years would have an infarct. And any particular intervention that we do will reduce that by about 1/3. So 1/3 with lipids, 1/3 with blood pressure. And you can actually click on things like, oh, if I lower their blood pressure or their cholesterol, you can actually see on here what it does to their risk factor. So it's a little bit easier. And then you can click on these, you know, little info things to get some more information to print out, give to your patients, and talk to them about, you know, what they need to do. So this aspect, I think, is really good for that next step of actually involving the patient into where we go next. Wait, there is more. Now, you saw at the bottom of the previous calculator, there was a thing called diabetes. We can now actually fine-tune this risk calculation for people with diabetes. So we're actually getting a much better risk. And you can just say diabetes, yes, no, but you can actually add in how many years. So we know people who've had diabetes for 10 years or more are going to be at really high risk. You can actually put in their current A1C, the microalbumin. Now, we know that any person with diabetes who has microalbuminuria actually puts them at one of the highest risks of dying. So it's important that goes in there. And of course, lately we've been really focusing on how important EGFR is in that risk calculation for people with heart disease. You know, as you see now, you know, moderate to severe kidney disease automatically puts you in high risk. So that's it. And then of course we've got BMI. You know, that's where the metric of all the data, and then the use of insulin. So using this now, you can actually come up with a really quite detailed risk assessment of the person in front of you, and then you can show them on the graphic what it is that you're trying to do and whether they think they need treatment as much as what you think they need treatment. But anyway, so we've got a tool now, and today I was at the Heart Foundation. They're actually trying to promote this now as a screening program. It's not going to be a true screening one because we're actually targeting people at higher risk. But what we're trying to do is, you know, work out how we can get the vast majority of people over the age of 40 having something like this. Because when you look at it, it's a huge number of people that are at risk. And the last thing we want them to do is have those expensive, plumbers put in those beautiful little stents. We don't want them to lose heart muscle and end up with failure later on. So if we can capture these people early, prevent that first event, we're going to create a huge benefit for our patients and for our country, mind you. But what we've got to fight, we've got to find them. And then those that we do, we've got to get them on treatment. And, again, showing them the graphics about what the risk is, using things like the LIFE program, using, health coaches, or whatever works, but we've got to get them to accept the fact that they are at high risk and what they do matters. And so once we get them on treatment, we've got to talk to them about their numbers. And we've got to get people to know their numbers around blood pressure and lipids, and we've got to get them there. Therapeutic inertia, where really we should be intensifying, but for some reason we don't. We've got to get against that. We've got to get people down. So really what I'm on about is I really want to prevent that first infarct. Once they've lost the muscle, it's gone. All right. So if we can stop that from happening, great. The other thing is that there are a large group of people who, with their first event, never get the opportunity to have a stent. So, 2/3 of those, of that 17%, die immediately from a heart attack and a collapse. So, or another way, 1 in 4 people will die from a heart attack, die within the first hour of their symptoms. I mean, that's frightening. So again, if we wait for the event, we're going to lose people. If we find them and treat them, hopefully we'll stop a lot of that from happening. And hopefully we'll then free up our ambulances so they don't have to stack so hard in the emergency department. So why do I like health checks? I mean, from a payment perspective, they're not exactly great. I mean, but the beauty is they have an item number. If you've got an item number, you can search on it. So you can search, all right, how many 699s have I actually done? In that, 45 to 50 or 50 to 60, how many people have we actually assessed? If it's 3%, are you happy with that? And what are you going to do about it? Because again, what you do will actually save lives. And that's absolutely true. And certainly out in the West, a lot of people, turn up very late to the emergency department. So really, it's a great way of actually searching and finding people, then actually assessing what their risk is and getting them on board and showing them where their risk is, and then doing something about it. Because again, if we prevent that first event from ever happening, we've won. The beauty is you can actually make it as an annual event. So once you've actually called them in, you put a reminder. Look, you're doing well, your risk is low, but maybe borderline low. How about we review this in a year's time and see how you're going? In the meantime, you can talk about, things like the Mediterranean diet or the DASH diet and getting them being more active. And of course, like I said, you can search on the 699. That is easy. Anyone can do that. The other thing is I'm busy. So I like to give the work to my nurses. So I know Lauren's going to love this part of it, because I reckon the more I can get my nurse doing it, the more free time I get to do other assessments or things. But it is true. The nurse can actually do the vast majority of the heart health check. And so when you're coming in, you're then getting an evaluation of where that person's risk. And of course, what you then say matters. Oh, you're at really high risk. Gee, we need to do something. Of course, that's then adding to exactly what the nurses just said. And hopefully then the patient will follow through. So then, we can actually do something, and we can do it on an annual basis. We can make sure that we check these people. And look, sometimes you do get a surprise. I've done a heart health check on someone. I said, oh, I assessed them as, they came back as intermediate. I was saying, oh, I don't think I trust this. So I did a CT coronary calcium score, and it came back like nearly 500. And I've gone, wow. And so I'm talking to him. Then he says, oh, actually, by the way, when I get to the top of my stairs, I do feel my heart race a bit and I do feel a bit tight. And I'm thinking, oh, you know, if only he would have told me in the beginning, we could have bypassed all of that. But so occasionally you do get a shock because people do downplay their symptoms. So that's what I'd like to end on. What you do as GPs, nurses, practice managers, receptionists, it all makes a difference and all leads into actually saving lives. Thank you.
Oh, you'd think us, it's been 5 years since COVID and I still can't remember to take myself off from you. I will get there one day. All right. So thank you so much, Ralph. It's always such a pleasure to hear you talk because it actually comes down to patient care and patient outcomes, which I think can sometimes be lost. So it is really lovely to see the impact that these sorts of things have. So we did have one question in the chat, which is just around the LDL recommendations for an otherwise healthy population. Thoughts, Ralph?
Well, funny you should mention that because at the moment we don't actually have from the National Heart Foundation actually guidelines since 2012. So for someone who's actually well, we would say, well, it could be great to have an LDL greater than 2.5. But the point is we would never treat unless their cardiovascular risk was in the high so if they were at high risk, you would then treat it. But if they were 2.7, 2.8, but low risk, you wouldn't, because when you do it, their risk, it's not an issue. So you can see what we're trying to get away from is that individual risk factor to a risk matrix for that person. Whereas, if they're LDL and they had diabetes and they were over 60, you'd be saying primary prevention, bang, we're going to go down to 1.8 or less. So really it's contextual. There are many people who would say everyone's LDL should be less than 2, but I'm not going to put someone who's at low risk with an LDL 2.6 on a statin for the rest of their life, unless there was some particular risk in the family or there was something to tell me that they had something wrong, or in fact their LDL was greater than 5 and I'm thinking, oh, maybe they've got familial hypercholesterolemia or something.
Wonderful. Thank you so much. So on us, yes, the 699 doesn't need to be bulk billed, Ralph.
Of course not. I mean, you may want to if you're doing it as part of a public health, but you don't have to. It's the same as any item number. You charge what you think the fee, what it's worth, and then they'll get a gap as per usual.
Wonderful. All right, so I'm going to hand over to the exceptional Lauren, who is going to talk to us about the nurse's role in the CVD risk assessment process, and I'd like to touch on referral resources. So take it away, Lauren.
Thanks, Natalie. Hi, everyone. My name is Lauren. I'm a registered nurse who is truly passionate about primary healthcare nursing. Building on our previous points, now let's focus on the nurse's role in heart health. As you know, the burden of cardiovascular disease remains high in Australia, and emphasizing the importance of routine preventative heart health checks. So today I'll be discussing the nurse's role in a heart health check, and second, the step-by-step guide on how to perform this heart health check. And additionally, I'll share some valuable patient education resources to help you support your patients effectively. An essential role of nurses in cardiovascular health checks is to collect patients' information and document CVD risk factors. Moreover, nurses should identify quality improvement activities that align with PIP-QI incentive requirements. One of the tools I really love and utilize a lot is PenCat. PenCat is the invaluable tool for enhancing patient care and identifying at-risk individuals. So in order for you to identify patients eligible for the heart health check, who are low, moderate, and high risk of CVD by using PenCat. First, on the general tab, you can enter age, start age and active status. And then on the conditions tab, select a no for existing CVD. On the MBS attendance tab, you can exclude all patients with health assessments or heart health checks claimed in the past 12 months. But you will only see the items that have been claimed in your practice. So if you don't see the item 177, it might be because it has never been claimed at your practice. Now all filter criteria have been set, so you can click on recalculate to apply the filter. Then voila, you'll see beautiful graphs. So you can select the low, medium, high, and automatic high risk categories by clicking on the respective colored square in the legend. You have the option to extract the data in PDF format as well. Educating patients about, excuse me. Educating patients about modifiable risk factors is paramount in preventing and managing cardiovascular disease. When patients understand the connection between their lifestyle choices and their heart health, they're more likely to adopt positive changes. So this knowledge actually empowers individuals to take control of their health and reduce their risk of heart disease, stroke, and other related complications. And also, please use Heart Foundation. I'll introduce the Heart Foundation in more detail later, but it is a valuable resource for patient education and engagement. As a nurse, it is also important to understand the MBS compliance requirements for items 699 and 177. Usually, mainly we use 699, but the main difference between two is item 699 is the heart health assessment by a general practitioner, whereas item 177 is by prescribed medical practitioner, for instance, non-vocational registered GP. But both items provide patients with a comprehensive assessment of their cardiovascular health and identification of any physical or lifestyle-related risks to their heart health. Also, implementing GP management plans for at-risk patients and coordinating referrals to appropriate allied health professionals are essential components of comprehensive cardiovascular care as well. Teamwork. A collaborative approach is recommended when implementing the heart health check. So, work with your practice manager and admin staff to develop processes to identify eligible patients and to ensure reminders are sent to the patients. Now, how do we perform a heart health check as a practice nurse? The Heart Foundation outlines a 5-step approach to performing a heart health check. First, who needs a heart health check? You need to identify people for CVD risk. All people aged 45 to 79, people with diabetes from 35, First Nations people from 30 years old. Step 2, use calculator to assess CVD risk. Dr. Ralph clearly and thoroughly explained how to use the calculator, so I'll just focus on the nurse's role in providing the clinical measurements needed for the calculation. So as a nurse, you can start by, providing a brief explanation of what a heart health check entails, and then you can gather some clinical measurements such as height, weight, blood pressure, and waist circumference. And you can also update, your practice software with family history, because it can help identify individuals with a genetic predisposition. Getting information on smoking status, alcohol consumption, and dietary habits is also important to understand their modifiable risk factors. Check their physical activity as well. Please let the patients know that though their work-related activity doesn't really count as an exercise. Nurses also can review blood test results. I understand that usually blood test results are discussed with the doctors, but nurses can clarify the meaning of each cholesterol marker. if you look at my mom's lipid profile results, I have obtained her consent to share her results with you guys today. But the report helpfully includes the normal reference ranges. So nurses definitely, certainly can review patients' blood test results to enhance their understanding. After completing calculation, this one. After completing the calculation, people can be placed into one of three risk categories: low, medium, intermediate, and high risk, which will determine the management approach. In addition to the variables included in the CVD risk calculator, clinicians should consider other reclassification factors that may help refine CVD risk categorization. Reclassification factors have been identified based on which factors are likely to improve risk estimation beyond traditional CVD risk prediction equations, including ethnicity, family history of premature CVD, chronic kidney disease, severe mental illness, and coronary artery calcium score. So reclassification factors are of most value, especially when person's risk lies close to a risk threshold, because even a small shift in risk estimate may result in their risk being categorized in a different risk category. Communication CVD risk is essential for informed consent and shared decision-making. We as a nurse can offer lifestyle counseling, including handouts and a discussion on one or two achievable lifestyle goals they may feel comfortable starting. When you do that, combine risk communication tools with the behavioral strategies such as motivational interviewing, personalized goal settings, and health coaching. And also, encouragement will help patients adopt healthier habits with ease. You can also communicate CVD risk by using a variety of formats, to enable people with varying health literacy needs and learning styles to understand their risk. So by effectively communicating the importance of heart health checks and nurses' role in this process, you can definitely contribute to raising awareness and promoting heart health within your community. Once the recommended management plan is identified according to risk category, this needs to be further refined in collaboration with patients. So this process should include a discussion regarding the benefits and risks of treatment options and their personal values and preferences. There are some useful education resources for you and patient. I've mentioned the Heart Foundation several times. The Heart Foundation is the leading resource for CVD assessment. It offers a comprehensive heart health check toolkit. You can also find a lot of useful information and various brochures that you can actually share with your patients. For more than 60 years, the Heart Foundation has been helping improve heart health across the nation. The Heart Foundation continues to lead the fight for Australians who live with heart disease through funding research, developing treatment guidelines for health professionals, supporting patient care, and helping Australians to live heart-healthy lifestyles. Not only that, you can download CVD assessment form and management template, a plan template directly from their website. You can also import the downloaded form and template into your medical software. The next resource is CVD Risk Calculator. You can access it by visiting cvdcheck.org.au, where you'll be able to use this calculator tool. Smoking is a major risk factor for cardiovascular disease. Quit is an invaluable resource for anyone on the journey to quit smoking. Hello Sunday Morning and Direct Line are excellent resources for those looking to change their relationship with alcohol. Last but not least, Aetna offers a module called Cardiovascular Disease Risk Assessment and Management, developed in collaboration with the Heart Foundations. So this course has been developed to provide primary healthcare nurses with knowledge of current guidelines for assessing and managing CVD risk. This course also provides 2 CPD hours, and it is free for EPNA members. So if you're an EPNA member and haven't completed yet, I highly recommend taking advantage of this valuable resource. Small changes can lead to big impacts, so let's inspire our patients to make heart-healthy choices. Thank you. Back to you, Natalie.
She's a lady after my own heart. Thank you so much, Lauren, for presenting that. That's all right, I keep managing to turn my chair off, so I keep falling backwards. Okay, so I think our next presenter, I'm so rapt. She was one of my first presenters I had on board, and I'm so excited for her to share her program with you. So many years ago was involved in the Work Health Checks program, and so have been long acquainted with the LIFE program. And I think we've always kept it in our minds as related to diabetes risk, but we sort of tend to forget that it is an option for patients who are identified at high risk of cardiovascular disease. So I hand over to you, Eleni, to tell us all about the LIFE program and refresh our memories about what's in it for us and our patients.
Thank you, Natalie. That'd be great. Next slide, please. I'd just like to make an acknowledgement before I start speaking. So I'd like to acknowledge the traditional custodians of the land on which we are meeting today, the Wurundjeri people of the Kulin Nations, and I extend this to the traditional custodians of the lands where you are located on, and pay respects to their elders past and present, and to any Aboriginal people present today. Okay, next slide, please. Yeah, Natalie, thank you for the introduction. We have been around for quite a while, I believe nearly 15 years, and we have delivered our program to quite a few people in the Northwest region. So we are known as the Type 2 Diabetes Prevention Program, but we are a cardiovascular disease prevention program too. So I really highlight the benefits that our program can have for your patients today. As some of you may know, because we have been around for a while, we are a free evidence-based program, and we are delivered by qualified health professionals. So essentially we deliver 7 sessions over 12 months. And it's really about assisting your patients to develop sustainable, healthy behaviours to help them reduce their risk. As Lauren was briefly mentioning before in her presentation, I think it's really great. We identify people at high risk, but then we really need to make suggestions and refer them on to programs to provide them with those tools to help them reduce their risk. So essentially our program, what we do is we have a session around nutrition, physical activity, stress management and goal setting, and assisting them to identify barriers and setbacks and how to overcome them. So it's really a holistic program, and it is all for your patients and individualized for them to help them develop SMART goals to really help reduce their risk in the long term. Yes, so research and development for our program. So really our program has come from the Finnish Diabetes Prevention Study, which I'm sure some of you may have heard of. So essentially people who participated in this study had a checkup 3 years after they finished the program, and people who achieved at least 4 of the program goals actually did not go on to develop diabetes, which was really reassuring. And other research has found that even up to 10 years, people who completed a prevention lifestyle disease program were 1/3 less likely to go on to develop type 2 diabetes. Next slide, please. So essentially our program, as some of you may know, our group course has been around for quite a while, so around those 15 years, but we have, I guess, come into the times of online, and thank you, COVID, for that, I guess. So we do deliver up our sessions through Zoom and through Microsoft Teams as well. We do also offer our program in language, so in Vietnamese, Arabic and Chinese, and plain English as well. And we also do have a telephone health coaching component to our program as well. So essentially, this is what our group course looks like. I won't go into too much detail. You can source further information on our website, but essentially, Session 1 is just a program overview. Session 2 is about healthy eating. So essentially, if the facilitator in the group course is, to say, a physiotherapist and not a dietitian, that Session 2 will be co-facilitated by dietitian as well. So essentially in that session, we're going over really practical things with your patient, like how to read food labels, what to do when you go grocery shopping, how to actually amend, what your current diet looks like, and how you can make small changes to really ensure it is heart healthy, which is what we're talking about today as one component. Session 3 is about physical activity. So again, to say if the dietitian is the key facilitator, that will be co-facilitated by a physiotherapist or an exercise physiologist. Session 4 is on wellbeing. So, as we can all appreciate, being health professionals and chatting with our patients and understanding health, we can tell someone to eat well, we can tell them to exercise, but if they're not actually managing their stress, excuse me, and mental health, they won't actually be able to implement those changes. So we do appreciate that. So essentially in those first 6 weeks, we're providing with all that information to make some changes. So then we actually, support them to implement those changes and then review them again in the 6-month time frame. We do have an online platform now too, which will support your patients in that interim, essentially providing with lots of resources, recipes, webinars, videos, and then we review them on that at 12 months as well to see how they're going, if there have been any barriers, and how can we help them overcome them, and then also just referring them on to any other resources in the community that they may need. Next slide, please. So yes, as I alluded to earlier, these are our streams of our program, and we have come a long way. So with our mainstream, we do have online and face-to-face, as with Arabic, Chinese, and Vietnamese. And we actually now do have a gestational diabetes specific program, although that's not what today's topic is about, just something good to know. Next slide, please. And essentially, this is just a quick overview of the telephone health coaching. Just the main difference, I guess, between the telephone health coaching and the group courses is telephone health coaching is a lot more personalised, as it is a one-on-one. So you have your facilitator and on the phone with you. So it's the first few sessions are 45 minutes, and they're 20 minutes, and then call 6 and 7 around 45 minutes again. Also, the great thing about telephone health coaching is very flexible. So if one of the goals of your patients is just to chat about nutrition, to reduce their risk of cardiovascular disease, or if it's, physical activity, it can all be tailored to actually help them with coaching around that goal. Next slide, please. We also are doing a Chinese pilot at the moment for telephone health coaching, which is really exciting as well for our Chinese patients and populations. This is just a quick slide again on gestational diabetes, which I won't go into too much detail about today. But essentially, yeah, we do have the modified program as well, just for your knowledge. Next slide, please. So I think it's really important for us to highlight the results of our program. This is from 2022. So in our group course, we did see a significant reduction in weight of 2.4 kilos, and telephone health coaching 3.6 kilos. And again, with waist circumference, 2.9 centimetres in group course and 4.1 centimetres for telephone health coaching. I think it's important to appreciate too, with anyone at high risk of developing cardiovascular disease and type 2 diabetes, not everyone actually is overweight. I know that is a risk factor, so just taking that into consideration with these results. But most importantly, 75% of live participants reported making positive changes to their diet and eating exercise habits. And I think that's really important, because we know You know, we're not advocates of these crazy crash diets that, you know, someone might do for 3 months and then kind of fall off the bandwagon there. You know, we really want sustainable lifestyle changes. And we know through the evidence that it's about small changes throughout your life that can make a big change to your risk, which is why we're all here today to support our patients. And just a quick note that 90% of life participants did rate the program as very good or excellent. So just to kind of reassure you, you know, if you are doing your heart health check CVD risk assessment for your patient and, you know, you're a bit hesitant to provide them with your own advice, you know, refer them on to Life. You know, we are evidence-based and we will be able to support them through their journey. Next slide. So essentially our eligibility criteria, I'll briefly go over A and C and mostly focus on B. But A is an AUSD risk and BMI, so the Australian Diabetes Risk Assessment. So if they're high risk and they have a BMI 25, but if they have Asian descent, a BMI of 23 is accepted. So essentially you can use your MBS item health assessments from 701 to 715. CVD risk category, we do now have the new CVD risk calculator that both Lauren and Ralph have spoken about. So this has changed a bit from previous eligibility. So now anyone at intermediate or high risk is actually eligible for our program, which is really exciting. And anyone with these pre-existing conditions, which maybe some of you are looking at now and thinking, oh my goodness, that's most of my patients. Well, probably is. Refer them to Life. We'd love to support them through their health journey. Just important to note our program exclusion criteria, and I think that's really important to note here today, because we know that anyone diagnosed with diabetes, as Lauren and Ralph mentioned, of course, are at higher risk through the calculator, but unfortunately, we are funded by the Department of Health as a prevention program, so that is an exclusion criteria for us. Now, the cardiovascular disease incident within 3 months, so even if you do have a patient, and I know we're talking about primary prevention here, but just say if you do have a patient that has had a myocardial infarction in the last month, refer them to our program. We will put them on a wait list and then we will see them after that 3-month period. Clinically active cancer, I think that's a pretty obvious one there. There's contraindications. And pregnancy. So again, if your patient is pregnant, refer them into our program and we'll put them on the wait list and we'll then enroll them into the program once they've had that baby. So next slide, please. Sorry, Lauren. Yeah, I think I've gone through all that. Next slide. Next slide, please. Yep. So this is our referral process. This is our referral form. Now, I'm sure most of you will be pleased to know that our referral form is available as a template that can be pre-populated in your medical software, including ZMed, Best Practice, Medical Director, and Genie. So essentially what you want to do is confirm the eligibility, hopefully through doing your heart health assessment, as we're talking about today. Great. And then you just obtain consent. We've got the consent at the bottom right-hand side there if they want to be enrolled in any kind of research, marketing, not a big deal there. But we do require some pathology just to ensure your patient isn't living with diabetes, to ensure that our funders are happy, and then rest assured, we will contact your patient within 24 to 48 hours and we will advise you of the outcome of the referral. So you will be informed throughout the journey of your patient in our program. You will hopefully be sent letters and faxes from our health professionals taking care of your patients, letting you know how they're actually progressing through the program. And yes, we do acknowledge that it is a tough time for general practice, and we do like to ensure that you are reimbursed for your time. So we do offer up to $45 plus GST for an eligible referral into our program, and that comes in 2 installments, $20 on referring your eligible patient, and then another $25 once your patient then completes the first session, so the introductory session of the program. So I think, yeah, it is really important to talk about financial viability of the Life program, and particularly I'm going to be focusing today on your heart health item numbers. So you can see there on the second line of the table, 4 heart health check item numbers. If you do them at $6.99, 20 minutes, $80. and you then go on to refer them into Life, which is reasonable as a recommendation if they're not currently living with diabetes. That's $500 for 1 hour and 20 minutes, their time. Equally, you can see how that fits in with your 703s, your 721s, 723s, and your 732s as well. So you can just see there how, yeah, really just by referring them into the program, there is a bit more of a financial viability there, you know, and we do appreciate, yeah, your time. Yes, and this is where I wanted to go here. So we have been working with, or we have worked with PenCS to develop an app in Top Bar. So I do believe most of you in Northwest PHN region use PenCS, which is exciting. And our app actually does everything for you. So essentially, you know, you'll see patient X, just say for a heart health check, or you'll see them for a general consultation. And then there'll be a notification that comes up that lets you know that your patient's actually eligible for the program. Our referral form will come up and it will be populated for you. Essentially, all you will need to do is fax that through to us. So if you are interested in referring into our program, if you're interested in the app, please get in touch with me. I would love to hear from you. And we also have recipes as well. And here are my contact details. Thank you.
That I remember to unmute myself before I talk. I'm making progress. Thank you so much, Eleni. It's always a pleasure to, I think, remember that this is available to us. I think I've referred so many patients over the years and seen really some incredible results, you know, and I think just in terms of patients feeling empowered to actually make changes, that they don't have to be huge changes. They don't have to be a complete overhaul of their lifestyle, but they do have someone in their corner supporting them the whole way. So thank you so much for coming and talking to us. So speaking of referrals, I'm just going to do a quick touch on what's available in our catchment, because there's a bit. Okay. So, now let me, there we go. So really, no one pathway fits all. I think that's the thing to remember. So we have our patient, they're at risk of cardiovascular disease. We have a wide suite of things that are available to us to assist that patient. Ralph has touched on secondary prevention, and as I'm not a doctor, I'm not going to touch on it, but take his words and incorporate them into your practice, because it is very important. I'm going to be lifestyle focused. So Life program, obviously we've discussed about that. It's a really great option. I was going to say it's really funny. I have a preference towards the telephone health coaching. Ralph has a preference towards group programs. So it just shows you that there's something for everyone. Private referral. So off to a dietitian, off to an exercise physiologist, off to a psychologist if their severe mental health is an issue. And obviously there's a couple of funding streams. So if they have private health insurance with extras cover, that's always an option. If they have chronic conditions, you know, that would also benefit from seeing those allied health professionals, you can incorporate it as part of their GPMP TCA for now until November, when it's changing. Obviously too, the patient can pay out of pocket and be self-funded. Group programs. A lot of community health services have a number of programs such as HEAL, healthy eating, active lifestyle. There's active, you know, group-based fitness classes. You could also consider, if you have quite a significant number of patient bases and time, having a nurse-led clinic in your practice dedicated towards reducing cardiovascular disease risk. Community health centres, again, for patients that may not be able to access private allied health providers because of cost. Most, in fact, I think all community health centres generally will have dietitians and exercise physiologists or physiotherapists available that can assist. Exercise prescription in your software. There will be an exercise prescription. So for such a little thing like writing on a bit of paper, you're going to walk for 20 minutes 3 times a week. The research actually shows that just giving them that bit of paper actually has some evidence behind it. So your task for tomorrow to go in your practice software and see where that exercise prescription lives and have a little play around with it. Lifestyle counselling, obviously that's where your practice nurse comes into account. If you've got a really great rapport with them and they do come and see you frequently for other things, it's something that you can spend that couple of minutes on when you're seeing them. The other thing to remember is if you do have a patient who is on a chronic disease management plan, remembering that you have your 5 items under MBS for practice nurse or Aboriginal health worker follow-up. So your 10997 or a 10950. So having time when they're coming in for their flu vaccination, talk to them about how they're going with their walking program. When they're coming in for their blood pressure check, ask them how they were going with trying to eat at least 1 serving of fish per week. All those little things. Combining this can build up to actually a really comprehensive lifestyle support modification program for your patients. So if you have no idea where to look in our catchment, health pathways. I will always talk about it because I love it so much. So if you're not familiar with health pathways, they are clinical resources that are written by clinicians and hospital-based specialists and GPs and subject matter experts that you can use at the point of care. So if you're not sure where to send someone or what the referral eligibility criteria are, the health pathway will tell you. And the idea is that your patient gets the right care in the right place at the right time. So when you first jump onto health pathways, this is the lovely home screen you will get. On the right-hand side, you'll find links to a number of useful resources. So I've really just pulled up some relevant ones for cardiovascular disease risk and lifestyle modification. So RACGP Red Book, which very excitingly had a lovely refresh this year, which is, I must admit, it's been my bedtime reading for a couple of weeks because she's a hefty tome now compared to what she was before. Better Health Channel, if you're wanting patient handout resources in layman's terms or lay ladies terms, for want of a better word. There are also referral pathways that are for our region and Eastern Melbourne. So if you look on the left-hand side, you'll see that we have health and community nursing, allied health referrals. So if you select any of the options and it brings up the health pathway, it will then tell you about what a dietitian is. I hope you all know what a dietitian is by this point in your careers, but if you're very new, welcome, have a read about what a dietitian does. If you're referring privately, if you use that drop down, it will then tell you what's available in our region, if there's a professional association where you can go and look for a provider, and it will also give some information on fees if that's available. Then if you're looking at referring to a public service, it will then have the details down below. So you can look at the criteria. You can also look specifically in the Northwest Melbourne or the Eastern Melbourne catchment where those providers are. Okay. The other thing, there is a whole section on lifestyle and preventative care. So I think a really interesting thing is I think we all know about our community health providers, allied health and group programs. There's also some really interesting stuff happening with councils, which is really exciting, that is actually included in these exercise and lifestyle modification programs. So the Heart Foundation walking program, so there's both walking groups. There's also people could sign up for a individualized walking plan, which I'm doing at the moment, and they send me a text message to remind me that I should be walking and just going for a walk to enjoy myself. So I can recommend that because I'm actually walking. There's also cycling groups, obviously life program referral information is in there as well. So we might just take a pause here and I'll have a little look. Thank you to Rel for putting in those resources for our First Nations peoples, which is great. Let's have a look.
There was a question about, can you claim different health assessments within the same year? Because I know it can get a little bit complicated. So I know you can do an intellectual health assessment and a diabetes health at separate times, but in the same 12 months. Lauren, do you know any more about the granularity around some of those co-claims?
Oh, sorry, I'll mute myself. I'll quickly share my
Because I think there was an issue once where you couldn't do like a diabetes,
I'll
and
quickly share.
yeah,
It's on my
because Medicare likes to make it so easy for us. I think Natalie has to close. I think Natalie has to close hers first.
Apologies.
So it says that the heart health assessment item can be claimed once per patient in a 12-month period, and the heart health assessment items cannot be claimed if a patient has had a health assessment service, excluding the Aboriginal Torres Strait Islanders people's health assessment in the previous 12 months.
And if I was going to do a diabetes health assessment and then a 45 to 49-year-old health assessment?
The 45, 49 is the health assessment, so it won't be claimed together.
So I can't do like a 45 to 49 and then a month later do a diabetes health assessment?
Diabetes health assessment,
No, you may not.
No.
But what you can do is you can do your diabetes 40 to 49-year-old assessment and then bring them back in 12 months to do a 699.
That's right. Yeah. This is where I was getting to, it can be a little bit complicated.
Yeah.
So basically, other than your 715 Aboriginal Torres Strait Islander health assessment, which is its standalone special one, the 700 suite cannot be billed within 12 months of a 699,177. Yeah. Which I will include that fact sheet in the resources when we send these out post
and of
session.
Course, one thing you didn't mention is that if they do have a care plan and diabetes, they can be eligible up to 8 group-based sessions. And a lot of your EPs love running them around activity.
Yes, they do. All right, let me have a look. So just a question about the MBS item number for a diabetes risk assessment. Yes, it's part of the health assessment suite for people aged 40 to 49. Okay. So we might move on, I think. So where to next? Because I never just leave you with a webinar and then leave you hanging on your own. So we are running a quality improvement program beginning in September, focused around cardiovascular disease risk recording and prevention in general practice. So the idea behind this is it's a peer-based program for GPs and the practice team that are based in the Northwest Melbourne PHN region. It has been accredited for 7 RACGP CPD hours. So there's 1 hour of educational activities, 2.5 hours of your reviewing performance, and 3.5 hours of those pesky measuring outcomes hours as part of the program. How it works is there's 2 peer-based learning workshops of 1 hour. So the first one is on the 11th of September and the final one is on the 30th of October. And in between those 2, you'll be provided with a quality improvement workbook to look at cardiovascular disease risk recording and lifestyle referrals in your practice. And you can work as much or as little as you like with your PHN relationship manager, who will support you through that program. Further information is available on our website. So if you jump onto Northwest or nwmphn.org.au under primary care, you can search for QI Spotlight. Or if you're really excited or running slightly low on hours as we approach the end of the year, you can scan that QR code there and that will take you to the registration form. But you are more than welcome to contact us at the PHN if you have any further questions. So that brings us to an end this evening. I've given you all 14 minutes back in your day. God, Pete, what are we going to do? So thank you so much all for coming and hanging around and listening to us. And I hope getting really enthused about cardiovascular disease risk assessment and lifestyle referral. So we would love some feedback. Good, bad, ugly, we love it all. So there's a QR code there, or there is a link in the chat that you can click on to provide your feedback. For those of you who have provided your details, a certificate will be received within 4 to 6 weeks of the session. And for those with RACGP numbers, your hours will be uploaded within 30 days. Obviously, we love a good education session. So there are, further events coming up, which you can access on our website, and we will send out the resources, including the slides from this post thing. So let me have a look. All right. Wonderful. Well, with that, I wish you all a pleasant evening. Thank you for coming along and happy risk assessmenting.
Good night, everyone.
Thank you.
Good night.